Good afternoon, everyone. There's a really big boat just going behind us there. We don't see boats that big in Australia, so if I'm a little bit awestruck, that's why. But I've got a very broad topic, from diagnosing to dosing. So I'm very grateful that of the previous speakers, Dr. Shastra as well as Dr. Diwale, for what they were able to present, which allows me to skip over some of those very important other issues, such as the timeliness of therapy, as well as source control. These are my disclosures. So these are the contents of what I intend to discuss today. Just very brief words on timeliness and source control, just to really emphasise how important those are, even from someone who's a pharmacist by training, such as myself, that I know how important those issues are. And then to focus on the antibiotic and what goes into the choices that we may make for using an antibiotic for an infection, the route, duration, and the dosing regimen as well, with a real focus on the dosing regimen because of the large amount of use of intravenous antibiotic therapy that we would use in critical illness. So, as we know, if someone develops an infection, it's a really bad sign in critical care. And there's a really strong body of literature since really the mid to late 1990s, which has quantified how important early and effective appropriate antibacterial therapy is for outcome in these patients. Now, diagnosis itself is a really big issue, and there's a lot of complexities depending on the type of pathology that there is, and so that's really something which should be considered for another talk, but I'm speaking about from the perspective of once the diagnosis have been made. And certainly, if we make an effective diagnosis because we're using definitions for the diagnosis for an infection as appropriately as possible, then this enables us to ensure that the patient receives better therapy which is more appropriate for the patient, and then we're not exposing them to harm of receiving surgical procedures or use of antibiotics which they don't need, given the possible adverse effects associated with both of those. So effective diagnosis really does lead to better therapy and will of course enhance the likelihood of better outcomes for patients. What are the consequences of inaccurate therapy? Well, I think this is really important for us to realise that if patients don't receive optimal therapy, then of course they're likely to fail treatment, which is exactly against what we're aiming for. But if we're using antibiotics for treatment of an infection, for example, and we're not using those antibiotics appropriately, then this can lead to the emergence of resistance, which may not only be a problem for that patient at that moment in time, but it may be a problem for that patient at a later period of time if they need a subsequent course of antibiotics. And it may become a problem for the general ICU community as well, as that multi-drug resistant isolate moves throughout the unit. And of course, drug toxicity is another issue as well. What about timing? Well, I don't need to speak too much about this because it was very nicely covered by Dr. Shastra, and essentially he presented the most recent literature which came from the Blue Journal about a week ago, but essentially what it highlights is that the greater the level of sickness severity, the more important the timing is for initiation of therapy. And whilst the initial data from Dr. Kumar in 2006 highlighted that it was very important in terms of septic shock, there's been subsequent studies which have suggested that it may not be as important in sepsis, but that it actually does now extend to severe sepsis as well. But I think that the words of Dr. Shastra are those which we should be paying close attention to in terms of the importance of timing. Certainly there's no real need to delay antibiotic therapy, but it's very important that we make sure that we are ensuring there's appropriate microbiological sampling and assessment of the patient to ensure that our diagnosis is as good as possible and that it informs our later therapy as well. So source control, again, I'm not going to speak very much about this because this is what's been highlighted by the previous speaker, but clearly this is all about removing the focus of infection, and if we can reduce the bacterial load for the patient, then that makes it a lot easier for the immune system, or alternatively the antibiotic, to be effective. And as Jan showed, that if you don't have source control, then that's essentially risking failure of antibiotics, even if your antibiotic dosing is appropriate. So antibiotic dosing without source control can be ineffective completely. So it's something which is very important, and not only does it extend to surgical and percutaneous procedures, but also it does extend to removal of lines and trying to remove any biofilm formation that may have occurred on any of those those surfaces that have been introduced. So one way that I like to think about maximising outcomes for treatment of infection is in this triad that we see here, whereby in terms of what we have control over in treatment of infection, it's quite limited. So if you think about what the players are in the treatment of infection, essentially you have the patient, which we would colloquially call the mug, mainly because it rhymes with the other two, which are the bug or the pathogen, as well as the drug, which is our therapy that we're choosing, assuming that we've already got source control, and I've noted that at the top right-hand corner of the slide. If you think about what we have choice over here, it's really the drug, which is the most important thing that we have an ability to modulate in terms of what drug we give, how we give the drug, and for what duration of therapy the patient receives, and do we use more than one antibiotic for treatment of this infection. And so this is where, once we've made our diagnosis and we've made our interventions related to source control, where a lot of our effort should be to make sure that we're optimising treatment for our patient. So that's why I wanted to spend most of my time talking about the antibiotic, and I think the antibiotic choice has again been nicely described by Dr. Shastra in terms of how important the timeliness is of an appropriate drug, and that's something which needs to be weighed up in the individual scenario of the type of pathology, what's known about the local pathogens in the unit, as well as what's known in the history for the patient from the microbiological surveillance. From a dosing perspective, in critical care, you'll all be aware that this is a very difficult area because we don't have drug dosing studies which are commonly undertaken as part of the registration process for drugs in our patients. If I could walk you through what the process is for developing a dosing regimen that makes it into the product information for a drug, is that essentially there will be a mouse or an experimental model of infection which is established, and essentially for a drug an exposure is defined which is shown to be effective against that pathogen or that particular in that particular animal model. Once that exposure is defined, then it's tested for safety and efficacy in relatively healthy patients to make sure that there's no severe toxic signs that are coming through associated with that new therapy. And then once it's known that it's safe to to achieve those concentrations in healthy volunteers, then it'll be tested in a relatively well and homogeneous group of patients in a clinical environment. It's very rare that critically ill patients are included in these studies, and certainly very rare that they're patients with septic shock and that have some of the characteristics of the patients that are being discussed in this session today. And so what that means is that we don't actually have any validation of the dosing regimens which have been developed, that they are appropriate for the patients that we treat who have these very high levels of sickness severity. And so for us to ensure that their patients are receiving optimal treatment, we need to adapt our practice to meet the needs of that individual patient and to try and achieve those exposures which were initially described to be most effective for those drugs. And so this is where it's a matter of understanding, well, what is happening in that individual patient? Where do they fit into that spectrum of organ function which is going to define how the drug is handled by the body? Are they going to be the kind of patient that's particularly hyperdynamic, has a very high cardiac output with retained organ function, such that with that high cardiac output we're getting increased perfusion of the eliminating organs, thereby leading to increased clearance of drug and low plasma concentrations? Are they a patient that's got septic shock and has received 5 to 10 or 15 litres of resuscitative fluids, which is going to increase the volume of distribution of some drugs like the beta-lactams, aminoglycosides and glycopeptides, causing an increased volume of distribution? Or are they someone who's at the other end of the spectrum, whereby they've actually gone into quite severe organ dysfunction, and so the clearance of the drugs is diminished? Or alternatively, are they someone whose organ function is so bad that they've had to receive some form of extracorporeal support, such as renal replacement therapy or ECMO, and therefore what are the effects of these on drug dosing? clearly, if you're not thinking about each of these different issues at the bedside when you're trying to work out what dose should a patient receive, then you're increasing the likelihood of them not receiving the dose which is correct for them, and therefore jeopardising the likelihood of having the optimal treatment. If I was to try and help quantify what some of these differences in pharmacokinetics are for ICU patients versus the data which has been described in healthy volunteers, you can see here that I've got a table whereby different drugs are listed on the left-hand column. The change in clearance and change is in the middle column relative to healthy volunteers, and the change in volume of distribution in ICU patients relative to healthy volunteers on the far right column. Essentially, you can see that there's consistently large increases in the level of clearance that occurs in ICU patients, and these will be patients that have retained organ function, not patients with acute kidney injury or receiving renal replacement therapy. And you can see that for many drugs that you see quite a large increase in volume of distribution that can occur. Certainly what this means is that in that initial phase of therapy whereby we're trying to ensure effective treatment in that first 24 to 48 hours, that if you don't use an adjusted dosing regimen for these patients, then you increase the likelihood of having suboptimal and potentially ineffective concentrations. One of the excellent initiatives from the European Society of Intensive Care Medicine, the infection section within that, was that this DALI study, which was essentially a point prevalence pharmacokinetic study looking at the concentrations of different antibiotics in 450 patients in 68 intensive care units throughout Europe. This data here describes the beta-lactam data, and you'll see here that there's 8 different beta-lactams which are listed on the x-axis versus concentration on the y-axis, which is recorded on a log2 scale. The point I want you to take away from this is that at a singular time point during a dosing interval, which is what this data is that there's a huge variation in concentrations that are present. And if you think that, when we are using a drug and we are trying to select a dose, we're essentially hoping that it's going to achieve a minimum concentration, whatever that may be at this stage. And you can see here that we're really very variable with what the concentrations that result from the doses that we choose. One of the major reasons for this is the change in renal function. Now, it's quite common for us to think about patients going into acute kidney injury or having some level of renal dysfunction to decrease doses, but it's not very common for us to think about increasing doses in patients that may develop an augmented renal function. And this study here from our group, I think quite nicely shows the importance of that, whereby on the x-axis we have creatinine clearance increasing up to 300 as this value here, and then we have a trough concentration MIC ratio for different beta-lactam antibiotics here in about just over 50 ICU patients. This purple line here is meant to reflect what a normal creatinine clearance is for perhaps us that are here today that are relatively healthy, a creatinine clearance between 120 and 130 ml per minute. And the point to note is the number of patients that have a creatinine clearance larger than this, and also that have what would be considered to be subtherapeutic concentrations as defined by this ratio here, ratio of 1, that for patients with a creatinine clearance greater than 130, they are far more likely to have subtherapeutic concentrations, and so it does highlight the importance of creatinine clearance. In terms of what does all of this mean, what is the importance of renal function? Well, this is a nice study from Dr. Devale's group looking at the failure rates of therapy for patients that had augmented renal clearance, so a creatinine clearance greater than 130 ml per minute, versus those that didn't have that, so they had a lower creatinine clearance. And essentially what was shown is that if you didn't have augmented renal clearance, then your likelihood of failure was about 13%, whereas if you did have augmented renal clearance, then your likelihood of failure was 27%, highlighting that patients with increased renal function actually are at a greater risk of failing treatment, even though we may think that they are more immunocompetent and then they may be more likely to deal with suboptimal therapy. This does highlight the fact that perhaps it is more likely to result in therapeutic failure. In terms of the things to think about in dosing antibiotics is that for different antibiotics that they have been classified in terms of what their pharmacodynamics are, and you'll know from your readings and from your teachings that essentially they're categorised in 3 different classes. They can be a time-dependent, concentration-dependent, or a group which is a mixture of the two, so which we describe as an AUC-MIC group. And the point I wanted to highlight here is the importance of the MIC. So essentially we've been talking about how important altered pharmacokinetics are. Now I wanted to talk about the importance of pharmacodynamics, and that pharmacodynamics is really crucially informed by what the MIC is, so that a very important measure of the susceptibility of a pathogen to an antibiotic. And you'll see that across each of these different categorizations that it's the denominator. And so as that increases, so does the pharmacokinetic numerator to ensure that the same pharmacodynamic index is achieved. In the critically ill, it's something which, as you would expect, that these patients are more likely to be infected by pathogens with decreased levels of susceptibility. We know there's more resistance that's present in critical care units. And this study, a German study here, which was a surveillance study of carbapenem MICs in patients in the intensive care unit versus the ward, very nicely quantified that, where you can see that for meropenem, doropenem and imipenem, that the MICs in the ICU were 2 to 3 dilutions higher than it was in a ward environment. And so now there's a lot of data which is showing that if we achieve effective concentrations of drugs, and you'll see that I've listed them there for a number of classes, that you're more likely to have increased clinical cure. In some scenarios, there's also data supporting increased survival as well. And so this really does show that in critically ill patients and patients with severe infections, that achieving predefined exposures does increase the likelihood of a good outcome, highlighting how important drug dosing is for these patients. If we return now to the DALI study and this time look at the PK-PD ratio on the y-axis and not just the concentration, but whereby we take into account what the MIC was that was known or alternatively suspected for the pathogens for the individual patients, we can see that the variability for each of the different drugs increases, and that there is a concerning number of patients which have PK-PD ratios which are below this very minimum ratio of 1, so a concentration MIC ratio less than 1. In this case, it was about 20% of patients that didn't achieve a ratio above this, and they were 3 times more likely to fail treatment. So this essentially highlights to us that our current dosing regimens are probably failing about 20% of our patients, and that we do need to adapt our current approaches to dosing to better achieve those targets. The DALI study was also able to define similar levels of subtherapeutic exposure for other drugs. So here's the data for vancomycin, whereby if we assume that a trough concentration of 15 is our target, that there's a large number of patients that don't achieve that target, which is particularly concerning given this is a drug for which we actually have therapeutic drug monitoring quite commonly available to adjust doses to make sure we achieve those targets. For Teicoplanin, which is used in some countries but not all, we can see here that if 10 milligram per litre or 20 milligram per litre is our target, depending on the severity of infection, that as a trough concentration, that there's a lot of patients that are as well dropping below that target too. For Colistin, this is some data from Thailand. This essentially shows on a log 10 scale here that there's a huge variation in exposures that result there, with this red line indicating what a desired exposure is at the end of the dosing interval, and there's a huge number of patients that don't achieve that exposure as well. So quite consistently across a lot of drugs, we are generally underdosing these patients. And so this means that we should be rethinking about how we go about dosing. And I'd like to propose that there's 3 different approaches that we could use. We could use a unit level based intervention, or we could apply a dosing nomogram to individual patients to improve dosing, or alternatively we could use therapeutic drug monitoring. So in terms of a unit level intervention, I might use the example of continuous infusions of beta-lactam antibiotics. Another example, of course, would be high dose aminoglycosides less frequently. But this is some data from a study called the BLISS study, which was conducted in Malaysia, 140 critically ill patients, a multi-centre study looking at the pharmacokinetics of piperacillin, meropenem and cefepime, and the comparative concentrations of these drugs with either continuous infusion, which are the blue boxes for piperacillin, you can see piperacillin here, meropenem and cefepime, And essentially what we saw quite consistently in this study is that the continuous infusion, as you'd expect, maintained better concentrations more consistently through the dosing regimen. So you'd expect that this would mean it's more likely to be associated with better outcomes. And so this individual patient data level meta-analysis from the Blue Journal, which was recently published at the end of 2016, essentially meta-analysed the randomised controlled trials in severe sepsis of this and show that there does appear to be an advantage in terms of hospital mortality and clinical cure with continuous infusion. For nomograms, we use the example of vancomycin here, that if you apply a dosing nomogram, you're more likely to achieve therapeutic concentrations. You can see here that's over 80% versus 50%. And then therapeutic drug monitoring. And I don't think I would need to talk too much about this. Essentially, if you measure the concentration of drug, you know what the exposure is in the individual patient, and it can tell you whether or not how you need to increase the dose for ensuring that that patient receives an optimal exposure. So in conclusion, I hope that I've been able to impress upon you that antibiotic dosing is very important. There is a clear concentration effect relationship for these in critically ill patients, and that we should be aiming for dosing regimens that achieve these targets, because if we do, we increase the likelihood of better clinical cure for our patients. So I'll conclude there. Thank you.